so excited to learn from him today. And with that, I'll turn the time over to you, Dr. Bishop.
Well, thank you, Cindy. That was a very kind introduction, and it's a pleasure to be here tonight because I think this is really an important topic. And I'm literally sitting in my clinic office and having just gone through this and have been pushing vaccines on all my patients. So a little bit about tonight. I'm going to switch to my presentation. And Cindy, can you see this?
Yep, it looks good.
All right. So what you're seeing, this is um, a view from our campus here at the University of Chicago. You can see the Chicago skyline behind there, but we're right at the same as the undergraduate campus of the University of Chicago, which makes it really nice because the students have just all come back to school lately. So I'll get started here. And so when Cindy presented this topic, I really started thinking about I wanted to do it from a patient perspective, and so the things that I thought about is um, I try to get my thing. Oh, there we go. Um, why are patients with blood cancers at more risk for infections? What causes a compromised immune system? Because that I've been giving you a sneak of what the response is to the first question. Why are infections more common during the winter time? What can I do to prevent infections? And I get that a frequent question when I'm in the clinic. And what do I do if I develop signs or symptoms of an infection? So we're going to try to take it from there. So the first is, why are patients with blood cancers at more risk for infections? And the biggest thing is that blood cancer patients often have a compromised immune system. Matter of fact, I don't know of a patient with a blood cancer who doesn't have a compromised immune system. And the reason for that, and again, an important thing is the immune system. I mean, you hear this word used all the time. Um, and the thing that I always try to emphasize is that it is a system, and the primary role of the immune system is to keep something foreign out of the body. And matter of fact, what we're trying to do primarily is keep viruses, bacterial, fungal elements out of our bodies. And that's what the immune system does. And you think of it, it has various barriers. As a matter of fact, the most important in one is how do these organisms enter our body, and they can go through various things. We can either inhale them in when we're taking a deep breath coming through our nose and into our mouth. We can ingest them by when we're eating, going down into our stomach. So actually, a lot of people don't realize one of the largest immune organs is your intestinal tract, and then we have our skin, and we all know that if you get a cut or whatever, that's a compromises and can allow organisms to get into that. So that's the first portion of the immune system. But what if they broach those barriers? Well, then you have the major things are your lymphocytes. And so the lymphocytes are a part of the immune system. I always talk about them as being policemen, and there's different types of policemen. There can be people just walking the street. There can be detectives. There can be undercover agents. There be special units. And matter of fact, the immune cells or the lymphocytes do that. And then there's you have the lymph nodes, and I kind of think about them as the police stations where they round up the subjects, they line them up in a line, they go, that's the guilty one, and there we go, and then they go out for his partners. And so again, all of these are intertwined. That's why we refer to it as immune system. And so how are it compromised? And so part of immune system, when you have low white blood cells. So if you look on your complete blood count, and you'll see that the white blood cells, and it can be relatively low, but there can be certain compartments or different types of white blood cells that can be low. So the one thing that commonly, particularly among patients with blood cancers, is they're always checking the neutrophils. And why they have to have why neutrophils are always checked is that lot of your therapies, they can't start until you have an adequate neutrophil level. And again, we know that neutrophils are extremely important for fighting bacterial and fungal infections. And so the neutrophils, I used to think, they're not the smartest cells in the whole world, but they're very good at killing things. So actually now there's some data showing that neutrophils are a little bit smarter than what I thought. But they really are guided by cells called lymphocytes. And again, lymphocytes can be very, very low because many of the treatments that we use to treat blood cancers actually direct upon lymphocytes. So if we think about patients who have multiple myeloma, that's a lymphocyte. That it was a B lymphocyte that became a plasma cell. If we think about patients with B cell lymphomas, so such as non-Hodgkin's lymphoma, actually Hodgkin's lymphoma, follicular lymphoma, those come from B lymphocytes, but patients can have lymphomas that actually come from T lymphocytes or T cells. And then there's acute lymphoblastic leukemia, which can be most primarily B cell lymphoma, but there's also acute T cell leukemia. And then we have in the myeloid acute myeloid leukemia, many of the drugs that we use actually target not trying to eliminate the acute myeloid leukemia, but actually kill the lymphocytes in the process. And then we think about one of the most common leukemias, chronic lymphocytic leukemia. And again, that's a B cell. And so we're B cell derived malignancy, and so we're often targeting that. And so, as I mentioned before, there's two different types of T cell, or lymphocytes. There's T cells, or known as T lymphocytes, and I can even break those down into different kinds. There's known as CD4 T cells, CD8 T cells. And that shows their differentiation in terms of how they coordinate in this immune system. But where T cells are really, really important is for fighting fighting viral infections indirectly. And then we have, I should say directly, but we also have B cells, and B cells also help viral infections, but they do it indirectly because they produce something called immunoglobulins. So you may look on your chart and you'll see measurement of immunoglobulins. There are three major immunoglobulins: immunoglobulin G, immunoglobulin A, and immunoglobulin M. And when we're looking at it in terms of how a patient is doing and how much their immune system, we really focus on immunoglobulin G. And so that's where you are provided immunity. And so when you get a vaccination, you develop antibodies towards that vaccine, be it influenza, be it people are getting Shingrix, so that's targeted zoster virus, and then there's the COVID virus. So you build up antibodies, and in that broad spectrum of just literally the billions of antibodies or immunoglobulins floating around, the chemotherapies and immune therapies they have can actually affect B cells, and it decreases the production of those antibodies. And we refer to, when there are low levels of immunoglobulins, we call it hypogammaglobulinemia. So it's hypo meaning low, and it's a gamma globulin or immunoglobulin, and it's in the blood. So we measure that there's low levels. And so there are things that we can do. We know that patients with very low immunoglobulin levels are more prone to infections, and sometimes we'll give some supplemental immunoglobulins in the form of intravenous immunoglobulin, or IVIG. And then the other thing that's why patients have a compromised immune system is that many of the treatments that we use compromise those immune barriers that I was talking about before, such as the skin. So when a patient gets a line placed, they get an IV line placed, or they have a port placed, or in some patients have an external catheter, that's a compromised area of the skin. So that's why your healthcare provider is so focused on keeping that area clean and protected in order to not be a portal for typical infection. And so what are some of the causes? What causes a compromised immune system? Well, almost every therapy we use to treat blood cancers compromises the immune system. We have just what I refer to as conventional chemotherapy. And as I mentioned before, often these cause lowering of the white blood cell counts, both the neutrophils and the lymphocytes. Radiation therapy can have an effect upon the immune system, particularly lymphocytes. Lymphocytes are very sensitive to radiation therapy. And then what is becoming almost standard of care for almost every blood cancer is immunotherapy. And when I refer to immunotherapy, that can be monoclonal antibodies. And a great example of that is rituximab. And rituximab is known to specifically target a protein on the surface of B cells, CD20, but it not only targets the protein on the lymphoma B cells, but it also on normal B cells. And this can lead to low levels of antibodies and cause that hypogammaglobulinemia. And what we're seeing now is a newer class of immunotherapy known as bispecific T cell engagers. And bispecific T cell engagers has really significantly impacted the treatment of acute lymphoblastic leukemia, B cell lymphomas, and multiple myeloma. And what these do is, when it calls a T cell engager, is it has two receptors. One engages the malignancy itself, and the other engages a T cell and brings them together to help fight the cancer. And then an area which I am heavily involved with is the use of cellular therapies. And we're very familiar with CAR T cells, and CAR T cells also usually target proteins that are on the surface of B cells and plasma cells. And so it does take out these malignant cells, but it also can have significant effect upon normal B cells. And in addition to this, before patients receive CAR T cell therapies, they've received very intensive chemotherapy that depletes the lymphocytes in the body, both B cells and T cells. And then we have autologous and allogeneic stem cell transplantation. And this is actually where we wipe out the immune system and replace it with a new one. But when the recovery of that new immune system can take several months, if not be even years. And so that patients who undergo an autologous and allogeneic stem cell transplant have very compromised immune systems and are very vulnerable to infections. And a thing that's probably very underappreciated is that the fact that a lot of these blood cancers are associated with inherent immune defects. So if you have involvement of the bone marrow, it often crowds out normal cells. So we have low white blood cells. And if you look at these patients, they can have low immunoglobulin levels associated with their disease. And for example, in multiple myeloma, you may have high immunoglobulin levels, but it's just a single one. It actually, if you look at the normal immunoglobulins within there, they're very, very low. And there's such diseases as chronic lymphocytic leukemia that even though it's a B cell disorder, if you look at the function of T cells in these patients, they're very, very low. And they're quite and highly vulnerable to viral infections. And as a matter of fact, one of the highest levels of COVID involvement is among patients who have chronic lymphocytic leukemia. And then another thing that causes a compromised immune system is poor nutrition. And if we think about patients who are undergoing therapy or even presenting at the time of diagnosis, they would have said, well, I've experienced a 20 to 30 pound weight loss. I've lost my appetite. I'm not eating well. And the nutrition plays an important role. So you take all of these things together, these various treatments and the inherent disorder and then the things that go along with it. And that's why the immune system is very, very compromised. So we particularly worry about well, let me just say one thing. I always worry about infection with all my patients. And I think if you met any of my patients, they probably get sick of me telling them to worry about infections. But particularly at this time of year, as we're coming up upon the winter time, that you have to be more and more careful about the development of infections. So why are infections more common during the winter time? One thing is that virus transmission is easier when it's cold. Actually, the coating on many viruses becomes more sticky. It actually heat. I mean, viruses hate heat. If you ever know why do we heat things up and what do it, and that's actually your body's immune response. Why do you develop a fever? Well, that fever is actually detrimental to a virus. It hates it. So, but the out coating makes it so when you might inhale a virus, it'll stick to that lining of your nose or in your throat or in the lungs and makes it, and once it gets into that lining, it can pass through and invade the body. And then the other thing is that during the winter, you can think about it, you have a dry throat, the humidity is very low. And if you think about, oh, my eyes are irritated. And so during these cold temperatures, low humidity, our eyes are drier, our mucous membranes are drier in our nose and in our mouth. And actually that dryness makes it, that barrier is compromised. So it makes viral passage through these mucous membranes much easier. Actually, it's been shown that inhaling cold air adversely affects the immune response in the respiratory tract. And a lot of us don't realize is that, again, anywhere where there's a portal, there's actually, it's very rich in immune cells lining our lungs. And it's been shown that cold air may adversely affect that. Another thing that's probably not appreciated is during the wintertime, we get less sunlight. We're not outside as much, but again, the days are shorter. But sunlight is a major source of vitamin D. And vitamin D is an essential element for the health of our immune system. So less sunlight leads to a compromised immune system then. And the other thing is, if you think about in winter, and again, where I'm actually, I was thinking about this morning as I was standing on the scale, and I saw that I gained another 5 to 10 pounds, that I go, well, I would increase my physical activity, but I'm coming up on the winter months where there's going to be a ton of food because of the holidays, and I'm going to be running less, and I don't think I'm going to have a major impact on my weight problem. But physical activity is very important. We know that the physical activity can actually enhance the immune system and is very important. So when during the winter months, we tend to have more. So all of these things together lead to the problem of an increased risk of an infection. So what can you do to help prevent infections? Well, one is to closely observe for signs and symptoms of infection. And I go over this almost every time with my patients, and I go, particularly, so I see a lot of transplant and CAR T cells, and I go, before you discharge, I go, these are the things that you need to be watching for. So what are some of the common signs and symptoms of infection? This include, number one is fever. And an important thing I always emphasize, and I actually look at when I'm teaching fellows and residents, that a lot of time we use a lot of steroids for the treatment of the various blood cancers. And just realize that steroids like prednisone are like super Tylenol. They will suppress a fever. So if you're on steroids, please realize that even a low grade temperature of like 99 is actually extremely concerning when one is on steroids. And again, often one can have an infection and not have a fever while on steroids. Chills and shakes. So all of a sudden, and again, I'll taste, well, I got cold, and I go, well, did you have a fever and then develop chills and shakes? As a matter of fact, having fever and chills and shakes are a strong sign of infection, and then sweats that go along with it. So all of a sudden I'm having a fever, and then I broke a sweat, and then I felt better. Well, and again, there can be surges in this as your immune system is responding to an infection in your body. Typical things, sinus congestion. All of a sudden I'm in a cold, I got a runny nose, sore throat, any type of new sore throat, new cough, whether it be productive of sputum or non-productive sputum, associated with pain with when you take a deep breath and it causes you to cough and you're trying to clear secretions. The onset of diarrhea, and I always hear, well, I ate some spicy foods, but again, where the bowel habit's normal. So, and when you're thinking about diarrhea, you're looking at the frequency of it. Is it uncontrolled? And this can lead to dehydration. Painful urination, so thinking about a bladder infection, or noting blood in the urine. So you can sometimes have blood in the urine, not necessarily have painful urination. That blood in the urine may be a reflection of a virus in the bladder. So paying attention for blood in the urine is important. Fatigue, all of a sudden, I just feel wiped out, and that could be the early signs of an oncoming infection. A decline in appetite, so if one has developed gastroenteritis, like a viral infection of the intestinal tract. Headache, this can be seen in almost everything. You can have a upper respiratory infection, have a headache. You can have, but big things are like, could you have viral meningitis? And again, some of our patients are compromised in that, but headache is commonly seen with infections. Difficulty concentrating, and I always talk about this. You think about when you get the flu, like you say, well, you sit down and you think I'm going to do some work, and it's much easier just to climb in bed and watch something simple on TV because it's difficult to concentrate. And then muscle and joint pain. So all of these together are some of the common signs and symptoms that one can see with infections. So what can you do to prevent infections? So one is we talked about observe very closely for the signs and symptoms of infection. Continue to monitor yourself, taking, if you're taking an occasional temperature, if you feel any type of warmth whatsoever. It's important to keep a healthy diet. In order to maintain, because your immune system is very dependent upon you having healthy foods, and actually to help maintain the health of your lymphocytes and your neutrophils. And it's also important to stay very, very well hydrated, because we talked about those mucosal membranes drying out. So they need to stay moist, and it actually improves your overall well-being by staying well hydrated. And when out, wear warm clothing and try to protect your eyes and mouth so that they don't get dried out by the wind and the low humidity. And probably the most important thing that you can do among all of the important things, and all of these are this, but is wash your hands, and continuously, because you come in contact with things. A lot of things are hand to mouth, and continuously washing your hands when you've been out and about. And again, it's hard not to. You're touching doorknobs, your hand railings, and various foods. So it's very imperative to wash your hands and carry hand cleaner with you, and wear a mask when you're outside of your home. And you're not expected, if you're in your home and with your um, who are their other family members, unless they're sick, is to wear a mask inside. But when you go out, it's important, if you're going to become in contact with anybody. Now, one thing I do say is, like, if you're going to go for a walk, say you live out far away and there's nobody on the street, and you say you want to go out and walk, you don't need to necessarily wear a mask there. You might want to wear some, like a scarf around there, to protect yourself from your mouth drying out. But wearing a mask all the time when you're walking out, or if all of a sudden you get a nice day, that's fine. But if you're going to be in contact with other individuals who you don't know outside of your home, it's imperative wear a mask. When you go to clinic, wear a mask. And hopefully in your clinic, the healthcare providers are all wearing masks, particularly when coming up, because you have all of these people who are immune system are compromised, and again, just the viral load and spreading. So wearing a mask to protect yourself and to protect others is important. Avoid crowded places, and this is really hard during the holidays, and when you're being invited, to do this, to go to various places. But and I always try to tell my patients, this is a short period of time that you can give this up. And again, just having that distance between individuals, because we know that as you get closer and closer, the probability of the transfer of a virus that can lead to infection uh, increases the closer that you get. And again, when you have a bunch of crowded people and you're passing by, you're coming in potentially large viral load. So the biggest thing I tell them to do is stay away. You know, people actually also they're religious, they want to go to their place of worship. I go, and I don't want them to do that. I go, if you can watch it on TV, do it. If there is a balcony where you can isolate, and again, at a bare minute, you know, and everybody wants to know how you are, and they want to give you a hug, and they want to shake your hands, but you really got to try to avoid that. And then when you, other than where where the general public is, you know, if you inevitably you have close friends, you have neighbors who care about you, and of course you have family, but you've got to let them know that if they have any signs or symptoms of infection, they need to stay away. So the same way that you need to observe for signs and symptoms of infection, your family, friends, and neighbors need to observe for signs and symptoms of infection. And if they love you, they're going to stay away. That's how I would kind of look about it. It's also important to get plenty of sleep. Sleep's also has been shown that, you know, the amount of hours of rest affects the immune system. And even though it's difficult, some degree of exercise is important. And, you know, I try to encourage my patients to, you know, to go outside and walk if the weather is permissible, just to get out and about, some fresh air. But you know, when, as I mentioned before, sometimes the weather is in hospitable, and so, but doing, you know, walking around the house, if you have an exercise bike or platform you can walk on, but get some degree of exercise just to try to keep your immune system up. And the other major thing that you can do is get recommended vaccinations. And so the important vaccinations during this period of time is influenza and COVID. And I'm going to get in a little bit of trouble, but don't let somebody tell you that they're ineffective in a compromised immune system. The answer is, will they be as effective as if your immune system was fine? And the answer is no, it won't. But there is clear evidence. As a matter of fact, in looking, like I do a lot of CAR T cell therapy, it really wipes out a patient's immune system. But it's amazing how that certain viruses, particularly COVID and influenza, that if you give the vaccine and you measure a patient's immune system, even though they go, well, your lymphocytes are squat, so you're not going to get an immune response. When you measure the immune response after you give these vaccinations, you can detect it. And from my standpoint, um, it's I'd rather have a little bit of immunity than no immunity. So if it's going to boost the immune system some degree, get the vaccination. The other thing is some people will tell you, well, these vaccines are worthless. I knew this person, she got a COVID vaccine, and you know what? She still got COVID. Well, that is true. You still can get COVID. The vaccine has been demonstrated to decrease the chance of you becoming symptomatic. And if you are symptomatic, it's shown that the vaccine didn't decrease the severity of those symptoms and shorten the duration as compared to people who did not get the vaccine. So I would encourage you to do that. And again, I'll get in a little trouble because you're going to go to your doctor's office on Monday and you're going to say to my Dr. Bishop, he or she may not want to give you vaccine because your immune system down or your antibodies are down, and they go, well, it's probably not going to do you any benefit. But then you go, well, Dr. Bishop said it did. And so you can have them call me and yell at me, but I would encourage you to do so. And then the important thing is to keep up with your scheduled appointments, because you sometimes things that you may not have seen, your healthcare provider, be it your nurse or be it your nurse practitioner or physician's assistant or your doctor, they're going to pick up signs and symptoms that you may have not. And then the laboratory values are going to be very important, seeing that if your neutrophils are down or they're measuring your immunoglobulin levels, that they can see that maybe you need some supplemental intravenous immunoglobulin. So it's very important. Don't pass up those things. And then this is important. So these are the ways you can prevent it. But what if you do develop signs and symptoms of infection? The primary thing you need to do is call your doctor. So, and I will say, or your healthcare provider. So this is something that I emphasize to all of my patients, because the earlier that we can treat an infection, the better the chances that they won't lead to significant problems. So like, with like, let's just say you get a pneumonia upper respiratory infection. There is a chance that that will lead to inflammation of the lungs and the need for oxygen, the need to come into the hospital. The analogy that I give is think about your yard. And I always tell my patients, I go, think about your yard in August and you go on vacation for 2 weeks, and August is a hot month, and you forgot to tell your neighbor if they would mind watering your yard while you're gone. Well, you come back after 2 weeks of vacation, your yard's all burnt up. So you have this burnt up yard. And so, and if you accidentally drop a match onto the yard, if you step on that match right away, you're going to have just a little burn mark there. If you let it sit there and watch it, all of a sudden be in 15 minutes, your yard's burnt up. And that's the same way what happens with infection. We know that the earlier the intervention, as I mentioned before, the better the chance we have of preventing it from spreading and becoming more severe. And I always tell my patients, you're never bothering me. If you develop this at 2 o'clock in the morning, call, at least you can discuss it. But often, we have patients come in because of that concern over infection, and we just don't want it to get bad. There are things that people can do for the various types of infections out there, beyond influenza, beyond there. So there's, and beyond COVID, there's things we can do for COVID. There's specific antibodies we can give. There's specific antivirals we can give. And for our broad things, we will give intravenous immunoglobulins to a patient who has active infections. And for a bacterial infection, we can get them on the appropriate antibiotics. So there are things we can do, and we can try to make things better. So don't hesitate to call. So I don't know how long I've gone, but hopefully this has been some useful information to you. So I want to thank you very much for your attention, and I want you to stay healthy. So, and these are things you can do. And so at this point in time, be glad to take some questions.
Perfect. Thank you so much, Dr. Bishop. It has been a pleasure just hearing information about the immune system in general, but then all the things that we've got to remember to stay healthy this cold and flu season. So we will have some time for a Q&A. We've got a lot of questions that have already started to build up in our Q&A. The first ones jump right into vaccinations. So I know you kind of started with vaccinations, and we talked about them a little bit at the end as well. But the questions around getting how often patients should get the COVID shot, also same thing with RSV. Are there specific recommendations? Is it an annual situation
Yeah.
or more
Yeah,
often?
so it's a really, really good question. So in general, um, the the for the COVID vaccination, when a new variant comes out, and so for very many months, so there's just been a new COVID vaccination that just came out, and we the COVID virus mutates pretty rapidly. And so then just a prior vaccination may not cover it. And it's very much like the influenza. Every year we get a new, I mean, that's a very smart virus, the influenza virus. So every year they try to come up and they try to provide a vaccine that will cover all those little proteins that the mutations cause. With COVID, it's it's not quite as often. They're in the early portion of that, we watched it mutate, and so they tried to come up with vaccines, and people are working on a more general vaccine that can overcome those mutations. That's what's being worked on now. So it's yearly in general for influenza, and then with COVID, whenever a new vaccine covering mutations come out. Now, that caveat is you have to take back what a patient's going through active treatment. And so the active treatment, so all of a sudden let's just say there's a patient who got a COVID vaccine in March and unfortunately was diagnosed in June with a new lymphoma and goes through 6 months of treatment with that lymphoma, even though they just had a vaccine. At the end of that treatment, their immune system is very compromised. And so we generally wait in that situation for the patient to recover for 3 months and get their immune system covered and then revaccinate. For my transplant and my CAR T cell patients, that's exactly what happens. As a matter of fact, with our CAR T cell, the current recommendations, they go through CAR T cell therapy, and at 3 months, doesn't matter what time of the year and whether or not they had a COVID vaccination right before that, they get a vaccination then, because you don't maintain with all those therapies that I was talking about before in the lecture had knocked that out. You hope that some of it remains, but not likely.
Absolutely. Thank you so much. I've got a question kind of in that same vein, just asking about needing to wait. So if a patient is getting IVIG, is there a waiting period before they could get a COVID or flu vaccine, or is that something?
That's a really great question. I just had that a patient ask me that question today. Like they just received, and I guess there is some thought that when you have the IVIG on, that when you that it may blunt the immune response because there's already circulating antibodies. However, you have to realize that when you give that vaccine and it's a localized, and patients are getting IVIG all the time, it's still beneficial because there are going to be B cells present. So that's what happens is when you give the vaccine, it turns on a B cell and turns it into which matures into a plasma cell that starts making antibodies. So I know there's some question about, right after you got IVIG therapy, but again, scientifically, to me, that's providing very broad immunity. And for these specific for viruses, giving the vaccine, I would still go ahead and I wouldn't wait just because I received recent IVIG.
Perfect. Thank you. I was thinking the same thing, just thinking through how vaccinations work. I think that's really wise. Got a question just about the hepatitis A and B vaccine and your recommendations for cancer survivors. Is that a revaccination situation or?
So it can be. So that's another good question. And so what we do is actually in that situation, because it's a pretty, broad response. It's that if you'd had prior vaccination. So what we do is measure titers, and you can and there are specific titers for hepatitis B and hepatitis. So if one had prior exposure, or if they have not, that we will measure titers, and it depends on specific populations, and look to see whether or not they need additional vaccination. So in our transplant patients, they do get hepatitis B reboosters. But in oncology patients, we would look to see whether or not they still had maybe some degree of immunity if they'd received prior vaccinations.
Perfect. Thank you so much. Got a bunch of questions just asking about Thanksgiving coming up, and what type of precautions, if any, that they should be taking. Is it safe to go to Thanksgiving dinner? And what type of conversation should be had around gatherings with
Yeah,
family?
so that's what I come back to those points. you know, it's hard. I mean, to me, Thanksgiving may be my favorite holiday of the year, and that's because I'm a glutton, number one, but it's also you're bringing family together, and so it's it really, I suggest, trying to limit the number of people who you're going to be. You need to space yourself from that if you're going to go. And for everybody, I mean, if you are going to go, and I try to dissuade it, to be honest, depending upon where they are in their treatment course. So like if I have a patient who's a month from CAR T cell therapy, I mean, I'm just saying no, that's going to be hard. So you got to say, where is your immune system at? And again, so if you're, and you should, and you need to know where you are therapy wise, and your doctor and or healthcare provider can put some degree of where your immune system is. But as I'd mentioned before, you know, if people are coming over and they all want to see if they have any degree of illness whatsoever, it should be not they shouldn't be there. And when you're there, you shouldn't, have somebody make a plate for you, be away. And if you're around these people, wear your mask, and wash your hands, and no hugging, no kissing. People want to do that. I knew it, but and have some fair distance. Like they go, well, I'm going to be in the far end of the living room. Everybody will be at the main table, but I'll be able to share and in the food. I mean, those are. I always say there's a lot of common sense to this, and so if you have to think if you have a slight worry, then it's probably a big worry, and so that's how I would do it. But I would I would advocate that you'll have hopefully more Thanksgivings in the future. And if you can just get past this one, try to avoid it. And if you do avoid it, make it limited. And again, follow some very strict rules about who you're in contact, who's supposed to come over, and anybody who's sick needs to stay away from you, and you need to stay away from them.
Absolutely. I think we are living in a great time for connecting in different ways. So in the event that you're not able to attend, I think it's a great idea to, connect over FaceTime or something like that so you're still involved, but keeping yourself safe is number one.
Yes,
So,
agreed.
perfect. I've got a question just about asking people to mask when they come into your home. If you've got workers that come in to clean your home, would it be appropriate to ask?
I think so, especially so because I mean, I think it's very nice. I think that, if they have any respect for what's going on, asking them because they're going to they're all over the place. And so you don't know who they've been exposed to, and there is an incubation time. So asking them to wash their hands uh, very, very well, and to wear a mask while they're in their home is appropriate. And then try to isolate yourself from that individual while they're cleaning your home.
Perfect. What about vitamins? Are there any vitamins that are
Yeah,
recommended?
that's a good question. So, I actually do encourage my patients to take multivitamins. Now there's a huge caveat there. So when you're on active chemotherapy, you need to really again go over your physician or your pharmacist. So I actually, a lot of my patients take supplements, but I actually have our pharmacist review every single supplement because, a lot of people like to take vitamin C and again the B complexes, and they're trying to boost their immune system. However, realize that a lot of those same things actually inhibit chemotherapy. So so I say, well, while you're receiving your chemotherapy, you should not be taking these medications. Now you can resume them after the chemotherapy. And, generally you can say, well, there's certain chemotherapies that clear out of your body in 24 hours. There's others that take a week. But during that period of time of administration and shortly thereafter, I try to avoid that. But otherwise, many, like I said, B vitamins, vitamin C are very beneficial. As a matter of fact, it's important for the health of your immune cells, like for folic acid, and that are very imperative for their health. That, and again, usually a multivitamin, at least in my eyes, is going to provide a lot of that, particularly because nutrition can be down. But so just be careful. Go over it with a pharmacist and your physician before doing it. But I do encourage that in order to maintain good nutritional health to promote your immune system.
Perfect. Thank you so much. Just got a question about how soon does the immune system, how soon is it considered recovered after treatment?
Uh,
Yeah,
it's a great question. So that I'm just going to give some general things. So I'll talk about my lymphoma patients. So we know, um, think of it's like a baby. And so generally right after you finish chemotherapy, and usually so you've received for lymphoma, for like rituximab, let's say, so you got R-CHOP, so rituximab, cyclophosphamide, adriamycin, vincristine, and prednisone. You generally don't have any significant immunity in about 3 months afterwards. And I always talk about it's kind of like, oh my gosh, I'm having my senior moment, but the Alamo, um, you know, it's enough to barely repel the army coming at you. I mean, that's where you're at 3 months. You go and we start saying you can do this, but you still got to be, cognizant that you're at risk for infection. When you get to about, and that you have about 10% immunity, but that 10% immunity is is just barely enough to maybe fight off infection for a while. And you still, when you get to 6 months, you have about 50% of your immunity, and you get to 9 months, you're up to about 75. And by a year, you're at 90%. We almost say it's hard to ever say that you get back 100% of your immunity, but it's a pretty healthy immune system if you have your immunity back at 90%. So that's kind of way to think about it.
perfect. More questions on vaccines. Any current recommendations regarding the shingles vaccine?
Wow. Yeah, so I'm a little bit, so this is where I don't know if it's controversial, but I don't think people appreciate, I mean, I don't, uh, we do recommend, we have recommended it. The most important thing, most of my patients, when they just want to get off acyclovir. I, I, I mean, acyclovir I look as a relatively benign drug, but it's just the idea of having to take that pill twice a day drives them crazy. And I understand you just want to feel normal. So the Shingrix vaccine, you have to be careful if you're still on like active treatment. Let's say a patient with multiple myeloma and they're on Revlimid maintenance, they have to realize their immune system is still semi-compromised. So the thing you see the Shingrix vaccine commercial on TV all the time. And for those, because and they recommend it for 65 and older, as we get older, your immune system does begin to drop. And so you don't want, all of a sudden your immune, because the way that what your immune system is protecting, because you have this zoster virus living in your spinal cord. And so when it drops, it like escapes from prison. And so what it's trying to do, because you haven't been exposed, is boost your immune system so it doesn't come back. It's about 80 to 90% effective in doing that and reducing so the incidence of 80 to 90% effective reducing outbreaks of shingles or zoster infection. What people don't realize is that it's only about 70 to 80% effective in patients who are already immune compromised from like chemotherapy. So among blood cancer patients. So I always tell my patient, I go, yes, just realize, it's going to significantly reduce by doing the Shingrix. And I encourage to do so. We look at their lymphocyte populations to try to say, could you have this? But I go, if it's not bugging you, I know that acyclovir is going to be about 95% plus. As a matter of fact, whenever I see a shingles episode in a patient who was on acyclovir, my first question is, were you taking your drug properly? Because it is a rare thing to develop shingles while on acyclovir. And so if you're not having problems with it, I always encourage to do that. Again, I am empathetic or sympathetic to the fact that, people hate taking pills. I don't want to take pills. So just know that when you take the Shingrix and you have a compromised immune system, it may not be as effective as acyclovir.
Perfect. I feel like that's been a common theme throughout, that the vaccines definitely are going to help, but you may not get that same immune response. So that's good information. Thank you. Got some questions just about COVID in general. So patients who have either been exposed or start to experience symptoms. Is there anything that could be done for them? Any sort
Yeah.
of
Yeah, no, there's a lot of things that can be done. So there's two uh, uh, actually antivirals out there is remdesivir. It really that the choice of the two, they go, why would they choose one over the other? And it's due to drug interactions. So they're going to look to see what medications the patient is on in order to do that. There's also antibodies out there. So for patients who have severe symptoms of COVID, they will give antibody-specific infusions of anti-COVID antibodies. Intravenous immunoglobulins, however, are commonly used. The first thing we do is somebody comes in with COVID, we measure their IgG levels, immunoglobulin G levels, and anything below 400 and they're symptomatic, and actually will argue for below 500 and symptomatic, and they're low on their immunoglobulin G, we're going to give intravenous immunoglobulins, and we will think about COVID-specific antibodies for the more severe symptoms.
Perfect. Thank you so much. I had a patient that just got COVID this week. I've never had it before. They were vaccinated previously. Is there a waiting period? So after they stop having symptoms, when they could or should get the vaccine again?
Yeah, so that's a really great question. I mean, getting COVID is the ultimate vaccine. So we generally recommend that if a patient has COVID, that at a minimum, the bare minimum they need to wait is 3 months, and often we'll say wait 6 months because they still probably have a pretty potent immune response having gone through the infection. And so that's in a patient who's not getting additional treatment. If they're getting additional treatment, we generally have them wait 3 months. If they're not getting treatment, I often have them wait 6 months before getting a new variant. I might even have them wait until the new variant comes out, even if it's more than 6 months. But I would generally say no sooner than 6 months in a patient not going through active treatment, because I would worry about a bad response having just had I had the ultimate vaccination in terms of infection.
Absolutely. Thank you. I had a question just asking about, it says regarding immunity, what laboratory levels should I pay attention to for my CBC, WBC differential, and
Yeah.
immunoglobulin
Okay,
testing?
that's a really good question. Um, the thing that I would probably say you can look at, I mean, the CBC is a crude indicator. So, but it is important to watch. So, watching, I think it's important that the two things that I would mention are, I guess, three, is you look at your total white blood cell count. So that's important. But again, you can have a patient with a normal white blood cell count, but their neutrophils may be very, very low. Or the major thing in terms of the immune system is the absolute lymphocyte count. So the absolute lymphocyte count, if you see that, and I would generally say when you have an absolute lymphocyte count of less than 1,000, that's showing you have a compromised immune system, and definitely is less than 500, because the absolute lymphocyte count contains all your B cells and all your T cells, and there's two major types of T cells. There's CD4 and CD8. Matter of fact, in AIDS patients, they measure the CD4 T cell count. So this is that, and again, if you have a level below 200, you're considered to have AIDS. And then I didn't mention a secret lymphocyte called natural killer cells. That's the innate immunity that you're born with. Matter of fact, in the baby's first year of life, they're dependent upon natural killer cells. And matter of fact, when you go through chemotherapy, your natural killer cells get knocked down, but they're the first cells to come back. They're your survival cells. That's the only thing sometimes you're hanging on for dear life are natural killer cells. They're there, they're sticking with you. So, but to answer the question, the thing I would follow most closely is probably absolute lymphocyte counts. And the other thing that hopefully, and it not always happens, is that is your physician or healthcare provider is also monitoring immunoglobulin levels. It's an easy test to do, and again, following that immunoglobulin G level. Don't worry about it. You'll see that your IgA and your IgM levels are low. Don't worry about that. They should be low. When you see them high, there's something else going on. You're even having an allergic reaction, or you were just exposed to something. It's your immunoglobulin G levels you got. So if you follow those, you can have you have some idea of what's going on with your immune system.
Perfect. Wonderful answers. Thank you so much. Just one more question about titers, specifically around measles with the, measles outbreaks going
Yeah,
around.
yeah.
Recommending titers for measles currently or no?
You know, um, we're using it to determine whether we are looking at titers to see whether it's sad. We thought we got rid of measles, at least we should have. But we do it for our transplant patients, and we wait, and because it's live virus, we wait until that after that year before we do it to make sure, because we know that the immune system takes a long time to build back up, like from the prior question. But we are now, I didn't think it was a problem until recently. And so we are doing titers, and that helps us determine whether or not to get the MMR vaccination.
Perfect. I think we'll do one last question, then we will have to call it a night. But just a question about maintenance treatments. What impact do maintenance treatments have on immunity?
Well, it depends on what the maintenance therapy is, but the two most common ones that we see are patients on let's say multiple myeloma. They're on, and matter of fact, yeah, the use of daratumumab has become a standard maintenance therapy, and then plus Revlimid. So Revlimid has mixed things. It has things that actually enhance the immune system. That's one of the reasons we think it works, but it also has things that knock down the immune system. Now, generally, now the higher recommendations is giving Revlimid with daratumumab, or one of the anti-CD38 monoclonal antibodies, and realize those anti-CD38 monoclonal antibodies target plasma cells, and your plasma cells make immunoglobulins. You make immunoglobulins, you have they're going to be lower. So again, levels. So it is difficult there. And then the other effect is a common maintenance therapy is rituximab. And rituximab is given for both follicular lymphoma and for mantle cell lymphoma as a pretty standard maintenance therapy, particularly mantle cell lymphoma. And then on top of that, you're with the mantle cell lymphoma, Bruton tyrosine kinase inhibitors have become standard therapy as maintenance, and they target B cells really potently. So they do compromise, but the benefits in all of these, and even though there's increased risk of infections with this, the benefits in terms of keeping disease under control outweighs that potential risk. But that's why you need to monitor for infections so closely.
Absolutely. Thank you so much. I know that was a very big question to throw at you
Yeah.
at the end. That was broad with all the different medications, but We just want to thank you so much, Dr. Bishop, for sharing your time and your expertise. I know I've learned a lot, and I know our community really appreciates you, so thank you.
Well, it's my pleasure, and it's glad to be able to, and I'm glad that we're thinking about this. And I think this program that you have serves such an important role. And the questions tonight were great. Really, really great questions. And I encourage you, don't hesitate to ask your healthcare providers. Put them to the challenge.
I love it. Thank you so much. We will let you go and close out the session. I know you've got a lot to get to, so thank you again.
Thank you. Everyone have a good night and happy holidays and a good winter season.
Absolutely. Thank you. All right, I'll just go ahead and share my screen again and we'll close out the session. I just want to remind everybody again, as you leave today, please take those 2 to 3 minutes to fill out the survey. It does help us know what you're looking for and hopefully answer those questions that are top of mind. I've got just a few of our upcoming events on the screen. So October 23rd, our Black Myeloma Health Group will hear from Benaya Hudson about breaking the silence, confronting multiple myeloma disparities in Black health. Saturday, October 25th, we've got our Austin Myeloma Roundtable. So if you live in or near Austin, we encourage you to register and attend. It's going to be a wonderful session. And then that same day, our Black Health Group has an in-person event. It's called Meet, Mingle, and Learn. It's at in Greenville, South Carolina, at the Phyllis Wheatley Community Center. These sessions offer space to share experience, ask questions, and receive information to help navigate care, make informed choices, and feel empowered along the way. I've only listed our next 3 events, but we also have a CLL and a caregiver event on October 27th, an AML event on October 29th, and an MPN event on October 30th. The registration pages for all of our upcoming events are available on our website, and I'll also send a link to those in the follow-up email. I'd like to again thank today's sponsor for this program, Vivid. And I want to thank you all again for joining us today. I'm so grateful for all of you. I've included my email address up on the screen. I really do love hearing from you and love to connect with all of you through email or different mediums. So thank you. I appreciate you all and hope you have a wonderful rest of your day and hope to see you again soon.